PCL, rather challenged to cover 3 different things in about 8 to 10 minutes. So I'll get going. First point to stress, PCL injuries in isolation are rare and post-lateral corner injuries in isolation are rare, or even rarer. So always think about the two together and always examine, and that really just goes to what we've been talking about in terms of examination. The classification system that I use for the posterior cruciate ligament, which in a multi-ligament injury may not be that necessary because structures are blown out all over the place, but in isolation it is useful because these classifications can actually guide some of your treatment. I use the Clancy classification, and a very simple test is just to put your thumb on the medial tibial plateau, and in a normal situation that plateau should be in front of your medial femoral condyle. As the PCL is injured, it will go gradually backwards and your thumb will become, it will palpate both the condyle and the plateau together. And there is a grading which is similar to most. PCL injuries in isolation can be missed acutely. There can be absolutely nothing, even less than some of those ACL injuries that we see, which don't even have a modicum of swelling or pain. There may be some very subtle bruising in the popliteal fossa, and that is it. But that doesn't mean you shouldn't check the limb out in toto, and certainly not forget the neurovascular status. The chronic picture is slightly different. One of the commonest presentations for a chronic PCL injury is actually anterior knee pain, and maybe some vague pain around the knee. And that is because when you section the PCL, there is an increase in pressure in the medial and patellofemoral compartments. So this study eloquently shows that increase in pressure in the medial compartment, and therefore it's no surprise that patients present with medial and anterior knee pain. Now, instability in PCL injuries is a curious thing. It is not the usual giving way that you would ask for with respect to ACL injuries, cutting and pivoting sports. Does your knee collapse underneath you? Over the years, one of the things that I go to is asking patients about stairs, and in particular, both up and down. When patients go down, they don't want to trust the knee that's about to bear weight. They just don't feel like by putting it down and then going down one more, it'll hold. And when they go up, they don't trust the knee in the flex position on the stair above to hoist them up. And that is because the tibia is moving front to back. In sport, a more subtle thing is deceleration. So they become a little more wary of decelerating quickly. So sports that may involve going forward and then backward very quickly, like football, might be something they're uncomfortable with. People often talk about the occupations such as being a fireman or something that involves a lot of kneeling that causes pain and instability, but I think that's increasingly difficult to tease out, and that's an occupational hazard, really. And then chronically, you might also see varus thrust, and if you see that, it's not only a PCL injury potentially, but do think about the post-lateral corner again. So bracing, really, really important part of PCL injury, and you'll see in a couple of slides' time why. PCLs probably have more of a grading of partial to full than our ACLs. I actually believe that some ACLs, once they're injured, just aren't normal anymore, and you can't really ask them to do the normal job. In PCLs, there is a chance that with the correct early management, you might get a reasonable outcome. And in grade 1 or grade 2 injuries of partial ACLs, there's a huge amount of literature to suggest that bracing will give good outcomes. What is interesting is that the literature is particularly sparse on the type of brace. That's quite interesting. So there's a lot of stuff out there in terms of bracing, but it's all very diverse. This brace, that brace, cast bracing. Is it the jack brace? Is it not? All braces should try and counteract this, which is when the knee flexes, the PCL lengthens. And so what a brace should do is to try and minimize that lengthening effect while the PCL is trying to heal. So there are 3 commonly used braces, and they're all trying to push the tibia back into a reduced position, i.e. forward. And that makes some sense in terms of the healing. You're reducing the external forces placed upon the knee and relying on some of the internal forces to gently increase the joint loads, but also mechanotransduction, which is a principle we normally think about with cartilage injuries and healing, actually is ligament-based as well, in the sense that if you gradually apply more and more pressure as time goes on to the ligament, you'll get more satisfactory healing. So I brace in all PCL injuries, whether I'm going to do surgery, whether I'm going to treat this non-operatively, whether I'm just going to do nothing. I'm going to brace everybody because brace has a role in everything. And in my view, braces should be worn for a minimum of 4 to 6 months, and that is a big ask of your patients. They get bored of them, they're clunky, and it's a bit of a problem. There's a great paper if you're interested in posterior cruciate ligament non-operative management protocols. This is really good. It lays out some excellent protocols that I use at UCL. And one of them, as you can see there, is in the prone knee flexions, the brace stays on. One of the common mistakes I think people make is to take the brace off, and that just allows it to sublux, particularly in the early phases. So the brace